using chemotherapy to treat these patients, a lot of folks are going to have different ideas. Some people like using Q3-week dosing, so carboplatin paclitaxel every 3 weeks for 6 cycles. Some folks will want to go ahead and use weekly dosing of paclitaxel and Q3-week dosing of carboplatin. I think both have pluses and minuses. If you have patients who are driving a good distance for their chemotherapy, it may be best to get on a Q3-week dosing. Some practitioners believe that a Q weekly dosing of the Taxol may increase a little of the response rate as well as decrease some of the side effects. To me, I generally prefer the Q3-week dosing, and what I'll do is if a patient gets primary debulked, they'll go ahead and get their debulking surgery, get their first dose of chemotherapy, and then what I prefer to do, especially in this patient who in my mind, stage 4, high risk for recurrence, she would have got carboplatin paclitaxel on her first treatment, and then starting with course 2, she would have got carboplatin paclitaxel with bevacizumab. To me, I think that that's a really safe way to do it, especially if she required a rectosigmoid resection or required extensive debulking that'll allow her to heal. And then after 6 courses of chemotherapy, reassess each time with CN-125. If she gets into remission or has a complete or partial response, then go on to additional bevacizumab therapy at that time. So for this patient, I think that we have a couple studies that have been done. We've had the weekly dosing of Taxol, but irregardless of carboplatin paclitaxel, GOG 182 was a study that looked at had patients at times received 8 cycles of chemotherapy, and it used novel combinations of doublets and triplet therapy. What we saw that it was equal outcomes, toxicities were different, but you can potentially substitute some of those drugs for upfront therapy. I'd say most of us would want to do a platinum taxane-based therapy and then add Avastin in if they believe that's the right thing to do. And you brought up about talking about maintenance therapy. We brought up how we're going to incorporate maintenance therapy into this patient. I think Avastin's a very good choice. It's been FDA approved. Avastin has been used in recurrent ovarian cancer, primary ovarian cancer. If you look at the NCCN guidelines at this point, Avastin's approved for maintenance therapy, pazotinib is approved for maintenance therapy, as well as Lynparza or olaparib is approved for maintenance therapy in patients who have a germline or somatic mutation in BRCA1. So I think maintenance therapy is important, and in this patient having high-risk disease, to me, I think she'd be an ideal candidate to go on maintenance therapy with Avastin. And I think the question that I would pose to myself is, I'll start treating her and base the treatment I just described, Q3-week dosing of Taxol and carboplatin, adding Avastin in, and then putting her on maintenance Avastin. Being that she's high risk, sometimes we think, should we keep them on Avastin until they recur or progress because of the high risk of relapse, or do we just do 15 treatments of bevacizumab after completion of primary chemotherapy?